Chala, heading the medical affairs at Zydus Healthcare Limited. I'm sure you and your family are safe and healthy during these current trying times. It gives us immense pleasure to invite you all today to an interesting talk on newer avenues in management of LDLC uncontrolled with statin therapy. We all know the very legendary Interheart study which said that dyslipidemia is the one single most important risk factor for cardiovascular disease. LDLC control has been the cornerstone with respect to cardiovascular disease management. We have guidelines which keep on getting refreshed for the benefit of the ailing patient. The 2016 ESC guideline and the 2019 ESC guideline, when compared, showed a very stringent LDLC control, with the levels getting more stringent in 2019. We had the famous Da Vinci study, which studied the control of LDL in lieu of these recent 2019 guideline and the more stringent LDLC criteria. And to our surprise, we found a very high percentage of patients in the overall population as well as in the high category population, high risk category population, still having uncontrolled LDLC. So uncontrolled LDLC remains a challenge. However, we have a new addition to the armamentarium in dyslipidemia management, Bempedoic acid, which addresses this gaps in therapy. And to enlighten us more on the same, it's my honor and privilege to introduce Dr. Prashant Advani, who actually needs no introduction, but it's my moral responsibility that I need to introduce him. Technical team, I assume that the slides are visible.
Yes.
So Dr. Prashant Advani is consultant clinical and preventive cardiologist, director at the Advani Heartline and Metabolic Center, Raipur. He's honorary and visiting consultant at various corporate hospitals in Raipur. He's a regular speaker at almost all national and regional cardiac and cardiometabolic events and congresses. He's published review articles and research papers in national and international index journals. He is passionate about disseminating current clinical knowledge pertaining to cardiovascular disease and cardiometabolic medicine amongst medical professionals, medical students, and pharmaceutical personnel through seminars, CMEs, conferences, and ad board. A warm welcome to Dr. Prashant Advani, and I request him to take the academic proceedings forward. Thank you very much.
Thank you, Dr. Sami, for kind introductions. That is for the opportunity. In the pandemic of webinars, this is yet another one, too interesting one, because a new molecule, and I think we must congratulate the host company for launching it and doing their pioneer work. And this is much needed, and I'll convince you with why it is very important in Indian society. This is the same company has given a huge, huge beneficial molecule that we all are utilizing. I'm in with my slides.
Yeah, we can see your slides. If you can just convert it to full screen. Yeah, the full screen is on.
Yeah, so and thanks, Sami, for setting the context and easing my job. The same company has given a salt like saroglitazar, which is so useful in us. So that we have in India, we have to improvise that come from and to take tweakings from the trials and the molecules getting released across the Atlantic. But we as Southeast Asians here or South Asians or Indians are vulnerable for these ASCVD-related events, and we have to be upping our ante, and all physicians or cardiologists or cardiovascular practitioner to be very receptive here in order to provide the best care to the needy, because what we see here, youngsters are having events, they have constellation of cardiovascular risk factor. They are not that so high, but they do accumulate in person. They have the clustering of severe, they're borderline as an event just 3 years into the diabetes, or borderline dyslipidemia, or not so bad looking LDL, but yet they have events. So we have to be circumspect in utilizing the molecules coming from the West and tweak it, promulgate it, and apply to our population with salt. We know that our ethnicity and epidemiological characteristics are different. So, likewise, we are using Lipagan for our patient for TG in spite of the so many years that we know that it's working and it's so safe and it's for so various comorbidity also it's improving. Yet it's approval from this is because Indians we have to decide ourselves for our own population, which is so vulnerable and so unique. We are very different genotype and phenotype. So this is a good evening again, and this is Dr. Prashant Advani, and I said it's about Bempedoic Acid. We have been hearing of it for the last 2 years, ever since the approval of USFD. And there could be an argument that the outcome trials have not yet come, and there's a proven safety and efficacy study for LDL lowering. We know that LDL is a huge, as Dr. Samir was telling, a huge risk factor also in India. Even an iota 1 millimole, or it's a 30 to 35 to 40 milligram percent persistence of LDL for say 2 or 3 extra years. Suppose some guy who is waking up to his LDL values and its importance to the cardiovasculature at 36, and this has been lingering ever since 32, and is ignoring our value of 103, 104, and it doesn't realize 103 and 104 for his kind of risk status is very high, and he's going by WhatsApp messages or social media information and Googling and all those kind of an unupdated inputs coming from here and he's losing first 3 or 4 important years of LDL. So you have to assign a goal to that individual. Youngsters at 28 or 32 have to have their destined or their assigned LDL goal, and by hook or crook we have to achieve. Of course, apart from lifestyle amendments, but lifestyle amendments miserably fail in achieving LDL goals. And again, to recapitulate, LDL is a very big, a very massive, a very, very obnoxious cardiovascular risk factor. And if it's any other accomplice or borderline hypertension or borderline dysglycemia, and the hapless fellow had it. So the topic is Bempedoic as an uncontrolled LDL. We are using statin. You know that statins are the millennial molecule. There's no question to challenge the hegemony of statins. Statins are gonna be there always. All those trials, millions of people, probably close to 1 billion people, we know that how statins benefited. But there's something in spite of statins, as Dr. was telling in various studies, Intraheart, Vinci, or so many Indian registry, hardly people are a sizable chunk, a very, very enormous chunks, so close to 60% to 3/4 are either on suboptimal levels or goals or dosing, or not at all when it's controlled that way. So we need some increasing the tools in our arsenal or armamentarium to make them achieve. They don't improve their lifestyle or risk factor. We have a pill solution in order for their own well-being, quality, quantity of life. So I said, statins have greatly reduced CV outcome. There's no doubt about it. Many patients at high CV risk have elevated, and despite statin, insufficient response to high intensity statin, which is not it's not so rampant, thankfully, but it is a real world scenario. It's a still scenario. I have prescribed 4280 mg of Etrova or 2040 Rosuva, but this guy is not coming to say at least 50% of drop. It's not. There's so many genetics, epigenetics. The factors are involved, and the CYP metabolism or gastrointestinal absorption, and then PKPD studies. There's so many things that are involved here. Or inability to take effective doses statins due to tolerability issue. Statins, even in the West, is a buzzword, and the most deserving people, in spite of irrespective of their literacy level, probably don't take because of statin-related myths. Still going on in 2022. This is so ironical. So if they are not taking statin, they have some myth attached to statin. So there must be some solution, because the same person knows the LDL is not good for his cardiovascular health. So additional oral options that complement maximal tolerated lipid therapy. So nowadays we say maximal tolerated or maximal intensity statin therapy, but the era is shifting towards high intensity lipid lowering than high intensity statin, because ultimately we have to, as Dr. Samir was saying, to designate it LDL goal for that individual. Bempedoic acid is a once daily oral small molecule drug being developed for the treatment, or it's already developed. It's been approved So this is where I'll set hover around, because we have to come to that LDL group. And if by just controlling a robust risk factor like LDL, an Indian, say, quasi young person who is from 18 years to 20 years to 50, 55, most of my cardiovascular, thousands of them are in between this thing. And there are events in 30. So ACS events are happening, hard events are happening in their late 20s and early 30s. So if I control LDL robustly, in spite of the fact that these guys don't, irrespective of exhortation, improve their lifestyle, yet they are protected. So we know that dyslipidemia is always a concern, and dyslipidemia is one of, in all these modifiable risk factors, is one of the very noxious and earnest contributor. And atherosclerosis is a major cause of it, and all this is LDL. LDL is the most positive. Of course, we talk of now remnant particles, non-HDL. In spite of everything, high intensity lipid lowering, maximum tolerated statin, ezetimibe, you still have residual cholesterol risk. LDL is very high. Then we have, that residual inflammatory risk. Then you have residual thrombotic. So we have to individual everything, precision medicine, irrespective of service specialty. We have to be an astute scientist for that individual sitting next to us to see that we got a dynamic risk assessment is the key, and we tune and eyeball the risk profile of that individual every visit. So we know that we have now newer concept and paradigms to change, and we have to embrace and set them into perspective to our needy patient in order to have them have a MACE-free survival. So lipoprotein contribution to SCVD is immense, as I know. LDL is the biggest culprit here, and then you have lipoprotein, little a and remnants, although not the crux of the topic today. LDL driven, because LDL, you need to control LDL, there's the residual. But if you don't control LDL, and from them, all these, instead of that, the fact that you control LDL, you have other things in the lipid domain is still as a cause, as a risk factor. But if you don't control LDL, you had it. So in spite of statin, the patient still continue to survive. And 3 key points: LDL is causal. Prolonged LDL exposure, I told you, as we have glycemic legacy, we have LDL legacy. So if you generate a good, the endothelium shouldn't be exposed to, for that individual, for amount of, so 120, 80 or 90 LDL could be normal for somebody, it could be very high for somebody. We shouldn't be analyzing the lab reports with the reference range given in just in front, and which many people, including doctors, actually make a folly there. And we know that primary prevention trial and secondary, because statins are the cornerstone. They will have the continued hegemony even in the future. But then in spite of the statin, lower is the better. We know that, as I'm telling you, as low. And thanks to the PCSK9 trials, we know that there is hardly any safety concern. Even LDL in single digit, 8, 10, or 11, or 12, 8, 9, or 7 is also not causing any neurocognitive decline or any other adverse untoward effect. So that's all has been rested. Yet you have targets set, and targets depending upon one individual's risk, and you have to individually assign, and they're getting lower and lower, because we know that LDL, if you lower, you lower the risk and the cardiovascular risk. This is the most important modifiable tool through innovative pharmacotherapy. In Da Vinci study, as he was alluding to, very high risk CVD patient, in spite of they had very continued high risk, they are 37 eligible patients were receiving high intensity. So meager abysmal penetration of this panaceal therapy to the needy, and 80% patient achieved lipid goals. In spite of the high intensity, they didn't achieve the lipid goal. So ever since all this, even after statin, residual risk is to the tune of 67%. As I was saying, the one for last 5 minutes, that in spite of that, in the first place, you are not on the statin, then you are not on a requisite dose of the statin, then you are not a requisite LDL. Or even if you are taking everything, in spite of that, there's residual, because there are so many LDL-related dyslipidemic stressor to the endothelium. And you have to assign risk, and LDL goal risk assessment has to be very important. We have to be circumspect and astute physician, erudite physician, to put a patient's risk extreme, very high. In India, in my experience, thousands of patients, extreme, very high, and extreme and very high. Some of them have high, but moderate to low is very low, because every, after 32, 30, most of the young adults, young, I will say under 50 are young, so they're the high risk of CV, so they are high. And one event or constellation of risk factor, one additional risk factor, dysglycemia, dyslipidemia, vasomotion, or smoking, or physical essential, you are very high. One event and you are extremely high risk for the rest of the. So this is so simple. And then you have an LDL goal less than 55, or lipid association in India coming into 40. So you have a score so many scores and or full cohort scores. You first stratify, but then always, if you're a good clinician, in just 2 minutes, as you start conversation with the patient, you eyeball their risk and you assign an LDL goal. And we know that in spite of all those health evaluation things that were terribly wrong, because even a quasi-normal looking coronary artery can give a sudden cardiac death or a major adverse cardiovascular syllabus. So we know that this is related to same plaque, and which LDL is one of the biggest stressor there. So many trials, we know the primary and secondary prevention statin trials, and now then gradually we had a very novel molecule, a PCSK9 inhibitors, which is kind of a bucket which collects the LDL circulating receptors from the circulation. So you express more LDL receptor. So this is in addition to statin, where you make the patient reach the requisite goal faster, and endure with that. And then clear program. So they started clear program for Bempedoic acid from their recruiting from 2016, and all safety efficacy I'll allude to is out, and how does it function, I'll tell you. So this is the spectrum timeline for lipid management. Primary prevention, statin trial, secondary prevention, then improve. There could be an argument ezetimibe, still not very. So there was an approval for ezetimibe even before an outcome trial like Improve. It was out. Improve IT was. So on the basis of, somebody can argue Bempedoic acid, the outcome trial is still pending. So yes, it's a little bit of approval. It's all safe, and it gives LDL incremental LDL lowering at a modest level. So modest LDL lower. And then in spite of the CVOT trial, I'll come to pending, it still can be very plausible in Indian setting to start prescribing for a patient to make them reach LDL goal. And we know that we have all these things, PCSK9, very robust, very powerful, safe, and they have hard outcome data. But they are injections and they are very expensive. And this is for all incremental addition. So you have optimized statin therapy, or the maximum dose or maximum tolerated, and then you have various things, ezetimibe added, or alirocumab or evolocumab. I've added on evolocumab a couple, but then it's very difficult in my level of practice. So very difficult. Means, but say, likewise, we talk of GLP-1 in literally in every conference, a very powerful, robust anti-diabetic molecule, and also a very safe, very, very robust data for MACE reduction and overall ASCVD related events. Yet we I'm not able to even at a tertiary care level because of they being injection and they being. So we need some therapy which is handy, which is just a pill and which is safe and just can be added without having to ponder much about it. And we have icosapent for triglycerides, but this is not just today. So Bempedoic acid. It's from the company Emerald, and this is Nexletol with the brand lowest LDL, and this is and also lowest HSCRP, which ezetimibe doesn't do. So you know that you have residual lipid risk, inflammation, subtle vascular smoldering inflammation is a big thing, and in terms of HSCRP reduction, goes long way, because the inflammation is something which inflammation oxidation in combo puts your vessel on fire, and HSCRP reduction, likewise, it's a kind of an off-target effect. And how does it act? It's act on the same HMGR pathway, like from alcoenzyme you cited and HMG-CoA reductase statin. So two step upstream in the same, and in the hepatocyte in the cholesterol synthesis pathway. So this is here. So I have simplified here. So you have ATP citrate lyase inhibition, two step up from the same statin pathway, and you there's a lesser generation of intrahepatocyte cholesterol, and there's the upregulation of LDL receptor. The same. So you're actually upregulating LDL receptors. All about cholesterol recycling, LDL receptor recycling. So this is in addition. This is where it goes in conjunction. So it is an addition. So they are in sync. So you have ezetimibe, prevents absorption from gut. Then you have statin. You prevent synthesis at HMGR receptor enzyme. Then you have ATP citrate lyase through in the same lineage of cascading events, which leads to cholesterol synthesis, a 21 step. So it's a very complex biochemistry, but it's where it's two steps upstream the cholesterol synthesis pathway where statins act. So HMGR, here ATP citrate lies. The good thing about it is that it's a pro-drug and it requires ACP synthase, which is not there in liver, which is in skeletal muscle, so it doesn't accumulate in skeletal muscle. So it's a very good choice for LDL lowering. Somebody who has got muscle symptoms and muscle aches and very well, like it's not so uncommon. Serious myositis with statins are very rare, but then statin-related symptoms are common. So if somebody is not tolerating at all, I do encounter people like that. It's a good choice because it doesn't accumulate at all in statin, unlike statins. So this is where it's a product. It's activated only in liver, and it acts again. I'm repeating 2 steps up in the same HMG coordinates. And then you have incremental therapy. You have PCSK9 synthesis inhibitor like oligosense or antisense oligonucleotide, and we know that we are on glycerin and all. PCSK9 inhibitor, which clears LDL, so MAVs, monoclonal antibodies. So this is how you marry one with another incrementally, and in addition to ultimate goal is to make that patient reach that designated LDL goal or below that goal. So LDLc is reduced by 15 to 20%, or could be 28%. If you combine it with ezetimibe, I'll show you a study, it could be 40% or plus. And it is in conjunction, it's an over and above maximal tolerated statin. So statins lower it, we know that moderate to high dose lower by 50%, close to 50%. So additional 15 to 25% or 28% lowering. And also non-HDL cholesterol lowering, decrease in apolipoprotein B and HSCRP, which is very important thing. This is a good pleiotropic effect that's coming from bempedoic acid. We have to actually see in the real world how it is out, and also then an outcome trial is CBOT trial is on, and reduction by just 4 to 6 weeks, as it happens with statins, and maintain then overall good tolerated. Hardly any adverse effect, except that it inhibits O2 in the kidneys, so it raises uric acid in the vulnerable people who are on comorbids, where you have interrupts like fluoroquinolones or very compromised CKD. You can have an episode of gout precipitated. It happened in their safety and efficacy studies, where you have to be very. So again, it's not a sort of grave cause of concern, but we have to circumspect the uric acid in gout, could be because it does, as it does ATP citrate lyase, ACL inhibition. And the similar way, the O2, same substrate there in the kidneys O2, so it raises uric acid level. And slight increase in creatinine, and if already the baseline function is below 3B, then what again was not a cause of the rest also. No increase in NOD, new onset of diabetes, again a concern with statins. So all those flip sides of statins are taken. Of course, statins are very robust LDL reducers. It is modest LDL reducer. And you have clear program, and they have clear program. So I have just made in a nutshell, just to bore you. Clear harmony, wisdom. They utilize them. These are safety and primarily safety and efficacy study. Also the secondary endpoints for some mortality things. All the secondary prevention, most of them, or heterozygous familial hypercholesterolemia on statins, already on maximum tolerated statins. On background of statin therapy, it additionally lowers the LDL, and that's how we want it to be used as. ASCVD, heterozygous FH, and diabetic hypertensive, and clear serenity and tranquility. There is statin intolerant people for safety efficacy, and everywhere it actually from 15 to 28%, depending on the important thing is that in the phase of bempedoic with ezetimibe in a fixed dose combination has already been approved. So somebody who doesn't tolerate statin at all, you have a fixed dose combination. This gives a close to 40% of LDL reduction without statin. That's something very, very interesting, and also a non-HDLc reduction. So in case of very hapless, where you're in statin intolerant patients, so many strategies, and you are not able to restart statin somehow, and you are looking for a therapy, and this guy is not taking PCSK9 or injection. So this is a very, very panacea and very innocuous, very easy to be prescribed of. Sure, the industry would come with this combination in future, but it can still be given bempedoic acid alone, which can still lower 25% of LDL for that individual. So clear outcome trial, which I'm looking forward to, was slated to be out by this time, March or April 2022. Been delayed a bit, could be out by this year. Just similarly, a high risk, and this is here, 14,000 odd patients, huge and multi-centric, multi-continental trial, a 14,000 plus patient, Most of them are history in statin intolerance. So statin intolerant patient with high CVD risk, so stable coronary syndromes, and one more risk factor, didn't tolerate, even randomized with bempedoic acid and placebo. This is like any CVOT trial that happens for diabetic drugs. So this is for bempedoic acid, and this is going out, and good signals are coming from this. Is something we'll know that, because ezetimibe, we had the outcome data after many years of its usage. Also, for statins, after many years of usage in primary, when you the outcome data, and we came to know of its pleiotropism and kind of extracurricular effect, off-target effects after many years. So we revisited. So could like this can also strike the same thing, unless we utilize the taste of the pudding, it's tasting. So and this is for a follow-up of 4 years, which already elapsed. Could be another year or so, and we'll be off with it. So this is something which the world is looking forward to. Its potential using, there is a very small molecule, once a day tablet, very safe. Additional 15 to 20% LDLc reduction. Patient on maximally tolerated statin and above thresholds. I think as I told you in the inception, 60 to 70% people are above threshold in spite of whatever. Statin intolerant patient, some patient with familial hypercholesterolemia, it does exist in India too. Probably you have to train an eye that FH does exist in India, and we have to look for it. I picked up around 9 people, boys here, and then and in retrospect, I traced their genetic pedigree, and they respond very well for incremental LDL lowering therapy, spearheaded by statin. And patients averse intolerant to injectable therapy. I see lots of my patients on the right from top to bottom, rural, urban, and hip-hop urbans, but they are very, very averse to injectable therapy. So you can talk whatever in the conferences, but when it comes to real world, injections are not so easy to be adopted, or also cost is a concern even to the one who drives Mercedes. So I think you need a molecule which actually provides the this kind of LDL goal through a very easy combination without much to be thought of, and which will actually in the Indian setting. Well, I think it's a initial way to go for our patients who are laden with risk factors. So take homes could be bempedoic acid has the same pathway as statin. We already told modest effects, but additive with ezetimibe and statins. And when we use the additional armamentarial lipid lowering medication, it's, and again some people were asking me yesterday, so the statin chala jayega? No, it's not here to replace statin. It's an additional help. It's a reinforcement to a statin, because statin alone, with all its might, not able to lower the LDL to the designated level to that individual, for that individual. So it's a reinforcement to the statin. Or if it's statin is dead, like in the war of statin death, so the journal has dead, now major is taking over. So it's here to statin intolerant, you have this thing. If you are not taking injection, if you don't want the Air Force to come, this is going to take over. So this is how it's like an incremental thing. But the mode of action is to it's the same as statins, 2-step up. An outcome trial is pending. If it comes positive, like a secondary prevention statin trial, it will be another millennium molecule, but that's time will tell. Safety and efficacy of severe risk reduction will be cardiovascular outcome trial of clear outcome as well. All those safety efficacy studies have shown signals that it actually by reducing HSCRP, good HbA1c reduction. So there are correlated advantages, but unless you follow prospectively, it's difficult, because all those safety efficacy studies were just to seek US approval, and many things are happening in the realm of it. So we have to just keep our hand and be receptive to it. And likewise, we know that if we used to give EPA, DHA, and all for TGs, and then now we know the DHA actually are totally contrary to the effect of EPA. The DHA nullifies EPA. So EPA, like icosapent, it's going knocking door again in India. We hope that the same company does with the EPA, DHA, India to EPA. So we are focusing here on LDL and bempedoic acid. This is from ASC. Small molecules, statin, ezetimibe, BA. This is in line. Monoclonal antibody MABs, like all PCSK9, and now we are discovering oral PCSK9. So many things are in research. Industry globally is researching. So this is where I think this is statin, ezetimibe, it's the same single line. And there's so many drugs here. Statins will be the cornerstone once again. PCSK9 and in addition, Bempedoic acid are promising agent. Bempedoic and inclisiran are promising new agents, and LDL again inclisiran is not the buzzword of it. And get LDL as low as you can for secondary prevention. And most of my patients, youngsters, are for secondary prevention. This is ironic. This is new, not algorithm. I say algo retime. And we are at either targeted therapy, PCSK9 or Bemped. If not, patient is not willing for injection, there's nothing left but bempedoic acid. So get to goal by optimal treatment, stratification, because certain benefits outweigh the risk, certain benefits outweigh the risk. And there's hardly any risk with bempedoic acid. So this is where I rest my case. Probably we'll discuss this we have some time. I just beg your pardon because I didn't know so much about it and I just spoke extempo. I stop here. Yeah, Dr. Samir.
Yeah, thanks, Dr. Advani. I think that was a great presentation, a very lucid one. And considering that the concept is new, you really unraveled the facts about bempedoic acid in a very lucid way. So thank you very much. And as I see the site where the questions are popping up, we are having a lot of positive feedback about your talk. There are a few questions, understandably, because since it is a new molecule, the audience is a bit eager to know few facts. So I'll just start with a question which is very clinically relevant. In the Indian scenario, what do you feel for LDL? How low is very low, in the Indian scenario? So that's our question.
Good question. Like you and me in our 40s or late 30s. So if my genetic, I have to first know my genetic lineage and then my lifestyle. I know that I don't smoke or I walk, and this again on my risk stratification thing. What's my lifestyle and how many modifiable, non-modifiable risk factors I'm laden with. So first I have to know. No one size fits all. So a Xerox copy of me may not be having the same LDL. Again, it's a risk-driven. Everything is at times I prescribe statins not for the LDL, the risk. So here you have to have risk assigned to that individual. If I assume the question is for secondary prevention, one ASCVD when there are repeat inordinate number of ACSAs and ASCVD detections at youngsters and rampantly. So the LDL is just moment you have an event, your LDL goal is 50 in India. This is the upper limit, this is the pinnacle I'm telling you. So I take them down to 40s and or 30 or 20 as the case may be. So if I say 50 or 55, could be 50% cases. I think statin and maximum tolerated kind of 40 or something might do it, in 60% again. But then still the remaining 35% who don't achieve is still a very sizable chunk in India because we are huge population and we are population at stake. So here comes the role of incremental therapy. Many patients I offered PCSK9 to 30, 40 of us people I have offered PCSK9, seeing that they can afford it. But 2 are continuing, 38 are not. So I'm looking for a molecule like this for incremental. I do use azithromycin for incrementally because like pill like Atrova E comes handy, but or separately. But this is something which I was looking forward and because it's come in India just recently. So a practical experience. Theoretically, I'm very clear where I'm going to prescribe, but practically, let's see how it fares over there on these type of patient on maximum tolerated or statin, and yet not on goal. And goal is lower in India. So somebody asked me, a good question, but for primary prevention, I would say 100. He's a healthy guy, no other thing, running, plays cricket, runs marathon. It's okay, 100 is fine. But I don't know why I'm still worried with 100. So in primary prevention too. But secondary prevention, 70 is good for Westerners. But for India, it's not 70. It's 50 or below. Or lipid association also keeps modifying it every year because they know that the events are, because I'm at tier 2 city or 3 city. I witness huge events and there's something, or I know that LDL reduction gives them protection. That's for sure. Irrespective of the exhortation I make them for lifestyle amendment, they don't do it. The pill does it for them.
Thank you. So that was a question by Dr. Shinde. Now we have a question from Dr. Shetty. The question is that in your clinical practice or in the Indian scenario, what could be the approximate incidence of statin intolerance?
Again, in my practice, say a pool of around 20 to 25,000 families. So I do my own registry and a statistical analysis. This epidemic state of CG and adjoining. And different population groups and subgroups, it is upper limit is 10%. Upper is 10%, and in some special kind of society, which I shouldn't be naming here, the incident 10 to 15% in that society. But otherwise, 5 to 10%. I'm not telling you of myositis or therapy stopping. Therapy stopping statin. It's for statin-induced myalgias or muscle pain or weakness. I'm including that thing where no CK elevation, but you still have statin, and you stop statin, your muscle pain goes away without any CK. So this is 5 to 10%. But if I say that 5 to 10%, in my, I'm not alluding to any registry or anything, because I can just present statin intolerance didactic lecture. You can have various data from various parts of the globe. But in my this where I'm sitting here, so I hardly stopped. I stopped, of course, to 1 or 2 or 3% of patients statins, because they couldn't even tolerate it in spite of trying. Of course, they do tolerate pitavastatin. That too, then if it's a very severe intolerant or they. So again, this is a molecule in these type of situation, 5 to 10%.
So Dr. Manjarekar has a question that you mentioned about side effects, possible side effects, although not very high incidence of uric acid increase with bempedoic acid. So if you place a patient with high uric acid on bempedoic acid, how frequently would one need to monitor the uric acid levels?
You start the therapy and monitor after 5 weeks. And check again after three months, so 12 weeks. And again, I have to take a call as it comes, because I do more of I imbibe everything when I do it practically. So this is a theory, but in our kind of setting, we are not researchers. We have to take a call as how the patient. I would do this way, because unless I've recruited 20 patients initially, and I see this way. 5 weeks and then 12 weeks. And if this guy is having a normal renal functions and no prior history of gout or any precipitating gout event, just a numerical uric acid coming around 6, 7, 8 doesn't matter. But you have to be wary of it. Of course, doesn't matter. And if it doesn't raise it, say after 5 weeks or 3 weeks, not gonna happen again. With prior gout attack, then you have to be careful. And then you have to periodically do it every 3 months or something, if it's not having gout attack. And if having gout attack, you challenge it, stop it, you challenge it 2 times, then you have to take a call. But then I don't think this is going to happen. This is just because the research driven, that their incidence was not so rampant in the trial also. As compared to placebo, it was 1.5%. And so that's where I think you have to be wary of it. Let's see it happens or not.
Dr. Bhattacharya has a question. If the patient is not tolerating even the lowest dose of statin, say for example 5 milligrams of atorvastatin, and the patient has got high LDL, and definitely that would pose him at high risk. So even in absence of statin therapy, would you like to prescribe bempedoic acid?
Yes, of course, yes. But this is where it is positioned, and this is where I think it's got the approval. And this is a panacea for those type of patients. And there are probably thousands or millions, hundreds of thousands of patients globally for this. Either they don't tolerate in real, or they have statin phobia. They are educated people who have statin phobia. I have people here with statin phobia. ये तो नहीं लूँगा सर मैं. मैंने बहुत सुना इसके बारे में. You convince what not? This guy is an MBA, or this guy is what? So you have a therapy, non-statin therapy now. The word statin removed, and this guy is okay now. But unless you again bombard WhatsApp with bempedoic acid again. So that's where misinformation afflicts your mind in such a way that in spite of a no nonsensical advice that you are giving for his own good, you waste your money, and this guy doesn't buzz. So this is where I think this is not also in US. I know I talk my colleague in Manchester, he says the same. So many people have statin phobia in the world. In spite of that, tolerance is fine. This is an objective thing. Statin. So you have statin phobias, you have statin intolerance. Bempedoic acid will have a immediate thought, because PCSK9 is a very powerful, very robust LDL reducers, and they are safe and they have hard outcome data. But at my level, I'm not able to penetrate through to the read. So they are more of theoretic, like GLP-1s. So here comes the bempedoic acid's role in management.
Thank you, Dr. Advani. There's an interesting question from Dr. Kumar. He says that bempedoic acid is shown to have beneficial effects in hsCRP. So as an add-on to maximally tolerated dose of statin, would this pleiotropic benefit of bempedoic acid have an edge over use of ezetimibe?
Of course, yes. Of course, this I realized only last week I was listening to talk and just standing, because hsCRP is a good metric, and we know that residual inflammatory risk is a huge concern in India. You cannot go for all these MAB and Cantor's trial. This is all so fancy and collegiate. No, you have a statin, then you combine with it, and this guy additional anti-inflammatory potential. So could be endothelial soother and improve vascular function, vascular cytoprotection. So this sounds very inciting. Or probably outcome trial will show that there would be a subset, I'm sure. So that this was a baseline hsCRP after this, and the clear outcomes will be all clear in a year. Clear will be clear in 1 year with all those things very lucidly. But as of now, this is so exciting. I showed you a bar in one of my slides that how hsCRP is compared to ezetimibe, because ezetimibe is just because it doesn't go to liver, it just does it in a human level. So how can you act on hsCRP? It is into your system. It is the same pivotal system where statin is acting 2 step up. So that's where I think this guy may be having bempedoic acid, BemTalk may be having the similar things even without statin. But with a statin, it can marry well. So a journal and a major journal just behind it.
Great. Dr. Manjrekar has a question that there is documented increase in new onset diabetes with statins. The pooled analysis of the trials suggests that there would be lesser chances of new onset diabetes, or it is reported that is the lesser chances of new onset diabetes as compared to placebo. So keeping in mind this is used over and above statin, and statin increases new onset diabetes, would this property help in mitigating the new onset diabetes?
Yeah, so one who has shown a dysglycemic status after starting a statin, and this guy is with laden with bugbears, and abni lunga sa sugar badta hai. So this is another subset. But this guy's bempedoic acid is very metabolic friendly, and one thing that we are not discussing, I told in my deliberation, it doesn't accumulate in muscles. So not only that, it is muscle friendly. It also, because of as the inhibition doesn't happen in the muscle product, and that as it is created, it makes muscle more sensitive to insulin. This is a collateral thing which probably a long prospective trial like Clear Outcome would tell us. But of course, if this is a corollary to which happens, and this is a good plus point to its addition, that it doesn't give NOD, and all those new onset diabetes concern of statin are rested with hardly any incidence.
Okay, so there is a feedback from Dr. Arvind Iyer from Vadodara, and he's complimented you, and he said that it was an excellent talk, Dr. Advani. So I just wanted to communicate the same to you. One more question which is there from Dr. Mehta is, in cases of primary prevention, where do you see the place of bempedoic acid?
Yeah, so primary prevention, high-risk primary prevention. In India, as I told, that whatever West says, average middle-aged or young Indian is at high risk, not low risk. This high risk is no-nonsense high risk, because one fine day, he would be flabbergasted or would be caught unaware with an event. So, and then all these test protocols, very traditional ones, are outdated and they don't predict events. So we have to be very proactive and circumspect and utilize all those molecular exist and extrapolate and promulgate and utilize our population with the pinch of and the dynamics and evidence. So if you have high risk primary prevention, so you assign a goal, as in one of the question I was telling. I say that you are even a school goer or college goer. Your LDL shouldn't be 100, even if there's no family history of premature heart or something, because we are in a different atmosphere here. The way it's happening, probably 4 5 years down the line, we realize that how heart attacks and heart events are happening to youngsters. And by reducing LDL by just 10 digits, 90 to 80, goes a long way. Your endothelial eased out. Your intraplaque inflammation of plaque composition, morphology changes. The thinning of the fibrogram becomes thicker. You do it by statin or you do it by anything. You have to. And of course, we know that statins are pleiotropism attached because the inflammatory cell also need mevalonic chain, and if they block it there, at least in acute setting, this is very important there. So if the guy is with a high risk primary prevention, I would first start with statin there also, because we know that statin is the first line of treatment. This will always be, and whichever drug comes. So for this guy, and it's going to be tolerating, but it doesn't achieve that LDL goal, say, which I assigned, say 60 for that time, 70. Then I think high risk primary prevention too, because they were in clear money program. There are many people who were heterozygous familial hypercholesteremia, cholesterol hovering around 190, LDL hovering around 196. They gave, say, rosuvastatin 40, it came to 80, or say it came to 110. They wanted it to be 70. They then needed bempedoic acid there. So here also, if I start with 162, I want it to come to 70, and this guy is stuck up at 84. 80, don't get complacent. Oh, 84 is okay, yaar, chalega. No. Ask him to come to 60. What PCSK9 wo lega nahi. Azithromycin liya, nahi liya, and how, depending on diet, may or may not function. I think azithromycin is benign. It's a very, this is modest. That is even lesser than modest, even mild to moderate. So probably I use both in that patient. But then pill burden, unless you guys come with a pill solution, a single combo with this. So there. Or this guy doesn't tolerate statin. Or the third is this guy is statin phobic. So maximum tolerated statin, the indication are same for high risk primary prevention or secondary prevention. You have to use statin. This guy comes to the goal, chapter is closed. If it doesn't, because so many of them, as I started with saying, you and me discussed that 60 to 70% in all registry don't consider. Could be physician inertia, could be patient inertia, or could be destiny. But now you have pill solution. We have to raise awareness, LDL goal-driven therapies, and they're all incremental, and they complement each other's actions. And this is the same LDL at the cholesterol LDL pathway, right from absorption to receptor synthesis, recycling, generation, messenger. One by one, we are targeting the steps. So this is how it has to be, even irrespective of the strategy of prevention or level of prevention.
Thank you, Dr. Advani. I think there are many questions.
But my time, yeah.
Yeah, so the questions
2, 3, 4 minutes,
repeated. So I think we have addressed almost all the questions which are raised by the audience. So before I just deliver the final vote of thanks, can we have the take-home messages from your end?
So I think we have to risk stratify patient in holistic. You have to see global CV risk. LDL is one of a very robust ones. If you took care of LDL, your more than 50% job has happened. But then this is, in spite of we all being vociferous, all industries vociferous, it's not happening. So this is another easy tool. Just prescribing a pill will do an additional purpose, and it will help statin very, very immensely. And this is so easy. This guy even doesn't do lifestyle. He still have his numbers getting corrected and risk coming down. And probably this cyber too is needed. Again, I re-emphasize emphatically, the indication is not to replace statin. You have to have statin in place, and then you have to see this guy's behavior. In 1.5 months to 3 months, take a call and add incrementally. I think this guy is Bempedoic Acid. Bemdex is better than ezetimibe, but it still can take Bempedoic, which is a pawn. This is a major general. Can all go together to fight LDL and make it come down to, it's powerless. It's 40 less, under 40, it is powerless. So this is where we have to come, and this is where we have to take advantage. And hardly any concern to monitor about. I beg your pardon, all colleagues, and because I have another one, and I think I request Dr. Sami to call today.
Yeah, so thanks, Dr. Advani. I think it was a great, lucid presentation. And more importantly, the concerns or the queries of the attending delegates were addressed by you in a very convincing way. So thank you very much for taking out time from your busy schedule, and thank you for all the audience for spending their time on a Saturday evening, which is a family time, to attend this session on a very innovative avenue in the management of uncontrolled LDLc. So let us all stay safe, stay healthy, and wish you all a very safe and healthy weekend. Thank you.
Bye. Thank you. Bye. Bye, Samir. Thank you. Bye.
Thank
Bye.
you.
Good day.
Bye. Bye.
See you. Catch up. Take care.